Good morning, I'm Acacia and this is Mason. Today we will be presenting on vertebrobasilar insufficiency and its interventions. Our objectives are to discuss the problems associated with VI, identify supporting interventions to address the problems, and explain how supporting interventions may address the problem. So before we begin, let's do a little review about VI. VI is a condition of poor blood flow in the posterior aspect of the brain. It is fed by two vertebral arteries that join to become the basilar artery. According to Dutton, VI signs and symptoms are dizziness, drop attacks, diplopia, dysarthria, dysphagia, ataxia of gait, nausea, numbness, and nystagmus. And if you all remember, I taught you all the acronym, which is 5 B's and 3 N's. So most of these symptoms are required for automatic referral to a physician. However, we do have a couple of dysfunctions and impairments that we can treat to eliminate the further signs and symptoms. So to start, we have decreased balance, impaired motor coordination, which is ataxia, and decreased cervical rotation. And we will begin with those interventions.
So our first one being interventions for addressing decreased balance. So before you do anything with BBI, you want to do a vertebral artery test to make sure they're not going to have signs and symptoms while we perform that. So for this, I'll have my patient lay on their back on the table. To perform this test, I'd be behind them. They would have their head off the table. I would rotate their head to the left and drop their head into extension. Can you count back from 10 for me?
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Do you have any dizziness with that or anything?
No.
And while I'm doing this, I'm observing her eyes to see if there's any nystagmus, and so that would be a positive for a vertebral artery test. I would also perform it going the other way.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
So once again, she didn't have any nystagmus in the eyes. Did you feel any dizziness with that?
I didn't.
Okay. So now we can address the interventions for decreased balance. So for the max phase, we would do standing on a firm surface such as this floor, and we would do feet together, stagger balance, tandem stance, and a single leg, and we would hold all these for 30 seconds. And so these are to improve balance and stability, reduce the risk of falls, as Acacia mentioned earlier, like a drop tax is a big thing with this, and this would also improve proprioception and vestibular efficiency. So first we'll do feet together. So I'll have my patient stand out, have their feet together, and just hold this position for 30 seconds. 30 seconds is up. A way to progress this is we could just have their eyes closed, but this is kind of first week stuff. We're just kind of getting a baseline. Then we would have them do a stagger stance, so left foot out in front for me. Hold that for 30 seconds. Once again, we could have their eyes closed, and then we would do right foot forward. And while all of this is happening, I would have a gait belt on my patient because we would be aware of the drop attacks and to just increase risk of falling for patients that have this. All right, you can go ahead and stop. Now we're gonna do tandem, so just one foot in front of the other. We would hold that for 30 seconds as well. And then we'll do left foot in front. 30 seconds, and then now we would just do single leg. Good. Do left leg. So like I said, this would all be during the max phase of protection. For the moderate phase, we would incorporate a Bosu ball into our interventions, and for this we would just do weight shifts or do single leg on the Bosu ball, and this is kind of to just rebuild the confidence that these patients may have like in unstable environments, and it would also improve balance once again. So for this, I would have them Since it's an unstable surface, I would raise the table up so they can hold onto the table if they need to. First, we'll start with the weight shifts. So she would space her feet about shoulder width apart and just slowly rock to the right and slowly rock to the left. Try to keep your head up and just, there you go. Good. So next we would do single leg. So for this, she would be standing in the middle of the Bosu ball, and she would hold this as long as she could for probably about 20 seconds, just starting out, 15, 20 seconds, and we'll do a couple sets of those. Switch to the left. And once again, I would have a gait belt in this scenario. You can hop off there. So for the minimum phase, we'll be doing the Bosu ball or just an unstable surface. We're using a Bosu ball in today's demonstration and interventions, and occasionally will be tossing me a ball with my feet shoulder width apart and with the staggered stance. So this is working on our reactive balance. It's to improve the hand-eye coordination, also helps to improve the postural stability, and once again, kind of like the last intervention, it strengthens proprioception and the somatosensory feedback to help prevent the falls in case they do have like a drop attack or vertigo at some point, things like that. So for this, I'll be once again on the Bosu ball. For this, I would have a tech beside me, so Seth, if you please stand beside me. And I would be shoulder width apart on the Bosu ball and just catching the ball, tossing it back while maintaining balance. Next, we would do the tandem stance. So that would be our minimum phase. Appreciate Seth. And that would be for kind of our reactive balance for when patients are on like an unstable surface or things like that. Next, we're going to address interventions to address the motor coordination that ataxia individuals may have with this condition. So for during the max phase, we'll incorporate a heel-to-toe walking. So this, once again, just improves the motor coordination and challenges the patient's ability for balance and coordination. So you're kind of just incorporating both the balance we did last time, but making this more functional now. This improves the patient's confidence to eliminate falls once again. So for this, I'll have my patient come in this line, and I would tell her to just try to touch her heel to your toe and walk in this straight line for me. And as a therapist here, you're always by their side in case they have loss of balance, ataxia, loose coordination, or they do have a drop attack. All right, we can turn back around. Good. So for the moderate phase, we would just walk in a straight line, kind of like Acacia just did. But while we're walking, we would rotate our heads. So this would strengthen the head movements that may cause the dizziness that the patients have. And it also challenges the vestibular ocular reflex. So performing this, I would have my patient on the same line again, and I would instruct her, when you walk, look to the left, go back center, look up, center, and then right, the whole time you walk. All right, we can turn around. Do you have any dizziness with this or anything? Feel like you're gonna fall? No. Okay, good. So during the minimum phase, we're going to incorporate kind of more motor coordination, and we're going to do karaoke and high knee walking. This just challenges like a different phase of gait And it might be functional to, patients that may like be stepping kind of in a yard or something like that. They're having to like go around obstacles. So for this, like the weight shifts we're going to perform and the head turns and the rotation movements will help the brain adapt to the sensory and motor inputs it's kind of learning. It will reinforce neuromuscular control, and it's strengthening the core and hip while we're doing this. So to instruct my patient with this, we would go left foot over the right, and then right foot over, left foot back, right foot over the left foot over. Good. We do the same thing back, we're just leading with the left leg now, or the right leg. Good.
So our final intervention is to address decreased cervical rotation. For this one, I'm just going to perform some passive range of motion. This can be done seated for an at-home exercise plan or in clinic. So first I'll show the one I would do in clinic. So I'm going to let the table down and actually shove it on your back, please. And this is providing a light stretch to the SCM, which is the primary rotator of the neck. So I'm going to bring the patient into slight extension. And first I'm going to side bend, because side bending is also a part of those muscles. And if I wanted to, I could rotate as well as I side bend. I can hold this for about 10 to 15 seconds, just providing a light stretch to the area. Bring it back to the center and go to the opposite way, side bending, rotating. And I'm stretching the opposite SCM while I rotate to the same side. Okay, and then the other one is just rotation. So, holding it for 10 to 15 seconds. Do you have any pain or dizziness with that?
I do not.
Okay, back to the center, and I will do the opposite side. 10 to 15 seconds. Any pain with that?
I do not.
All right, you can sit up. If the patient is doing well in clinic with that exercise or that passive range of motion, I could send him home with the same exercise using this towel. I'll instruct the patient to put the towel around your neck, and I want you to rotate using the opposite hands and using the towel as a assisted device. You can hold that at home for about 10 seconds as well, and I will have you go to each side about 10 times a day. How does that feel?
Feel soft.
You also can use other bands for this one. Next, I'll have you on your back. We're going to do some supine neck retraction and rotation. Okay, we'll have him on his back. I'll just instruct him to tuck your chin into the pillow. Hold that and rotate your head to the right, or your neck to the right. And you're maintaining that chin tuck the whole time. Okay, go back to the center and then the opposite direction. This is also targeting the SCM and the scalenes as well as the splenius muscles, and it engages the multifidus and suboccipital muscles. And I will have him do this about 10 to 15 reps. Okay. Next, for the minimum phase, I would have him in a quadruped position. I'm going to instruct you to do the same thing with the chin tuck, but I want you to make sure that your shoulder blades are relaxed. Okay, and go ahead and tuck your chin, and then rotate to the right. back to the center. To the left. This should not be a big movement at all. It should just be stretching, putting a little stretch on that muscle that rotates the neck. I will have him do 10 to 15 reps of these as well. Okay. Good. Okay. These are our references. Are there any questions?
Andrew?
You talked about the vestibular ocular reflex?
Yeah.
What was that?
So the vestibular ocular reflex is kind of like a neurological pathway that helps like stabilize the vision during head movements. So that's kind of why we incorporate it with the walking with head turns. And this kind of works by adjusting the eye movements opposite to the head motion. So like if you're going to the right, you kind of your eyes will go to the left. And if like, for instance, for vertebrobasilar insufficiency, when the blood flow is to the brain is compromised, this could kind of lead to like visual disturbances, kind of like a nystagmus, vertigo, dizziness, things like that.
Kiki.
What are some additional exercises you know to help improve circulation?
I would give chin tucks probably, just going back into that. Also isometric cervical exercises, so maybe rotating to the left and maybe placing your hand or a towel and pushing in to create that isometric exercise. Oh, I also could give shoulder shrugs because that works the upper and mid trap, so that'll also help with rotation of the cervical spine.
Okay.
When y'all went to the moderate phase, why did y'all go straight to BOSU ball instead of like doing something like a foam pad in between?
So this was kind of just from like personal experience. The CI shadowed this summer. He was really big into BOSU stuff, and I actually kind of contacted him for this. I was like, "What do you think, kind of for a moderate phase?" And he said, "Like I love the BOSU for balance." And then I knew I wanted to do kind of balance for the max phase on the BOSU. So you might as well kind of incorporate it now with the moderate phase, so they're not new to it when they're trying to like juggle things and throw it back with the or minimum phase. Sorry.
Jada.
So I saw that, I believe it was your moderate protection phase where you did the chin tucks and the rotation, but you also did it at the minimum protection phase. So I just want to know, like, how was that a progression of that treatment? Like, what's different in the supine position versus the large?
Okay. In the supine position, you have a cue, such as the pillow, or in the picture it shows the book, and it's letting the patient know where that proper movement or motion, or what it feels like and where it is. Versus in the quadruple position, you're using other muscles such as your triceps to stay up, your abdominals to stay in a neutral position, and you also don't have a cue as to where to tuck your chin. So it's teaching the patient proper alignment without a cue. Any other questions? Thank you all. Oh.
I have a question.
Yes, sir.
May I use this presentation to, as a serve as an example for my students?
Yes, sir.
I love it. I like the way y'all laid this out. Very big writing, easy to read, easy to follow. I love it. Excellent job.
Hey, just a comment on the chin tuck too, so you asked about supine versus quadruped, what's the effects of gravity supine versus quadruped as well? What do you think how would that affect? Supine gravity is helping you, right? And when you flip over to quadruped, now you're gonna work against that. What's another?
Okay. So one thing I want to go more in depth with is the SEM stretch. I know when you Google SEM stretch and things like that, they give you like a general way of stretching the SEM. And some would just say specifically side bend when you Google it. So for specificity of the SEM stretch, all right, so we know that when I rotate to the right, my left ACM is contracting concentrically, right? If I rotate to the left, My right SCM is contracted concentrically, right? That's it, right? So, what I really want to do for specificity, because the SCM has attachments to the occiput, right? But some people do, not everybody, some people may. So what I want to actually do is put the person in some flexion, all right? And I want to try to maintain that flexion. And so say if I want to stretch the left SCM, I'm going to side bend him to the right, and I'm maintaining this flexion. Some people get in here with the chest to maintain it, but I feel like I'm strong enough to maintain it with my hands, all right? So I get in here, I got him in flexion, and I got him side bend to the right, all right? Now I want to continue to elongate the SCM, because the SCM is like a sling, like a slingshot. Anybody ever shot a slingshot? Put a rock in that slingshot and shot it. And so what I want to do to get more stretch on this less SCM is I want to rotate him to the left. Maintain the flexion and rotate him to the left. Now the SCM is like a sling. It's more elongated like this. You see? Like this. Now, if I take that sling and pull it back and let it go, that rock is gonna go, right? So now I got this SCM more elongated when I rotate him to the left. So it's side bending opposite, side bending contralateral, rotation ipsilateral with maintaining some flexion. You're gonna get a greater stretch on the SCM. Has everybody got that? All right, thank you.
And can I add something there too?
Go ahead,
Just
Dr.
like
McClure.
you've done with the other techniques, like we learned with the biceps and like we learned with the pec, what does it attach to? Sternocleidomastoid, what is it attached to? Okay, so you can also, so you can get that position Dr. Carter just had him in, and you can take your other hand and you could provide some stabilization to the clavicle or the sternum and get even more in-depth stretch, just like we did with those techniques we learned yesterday, or, yeah, Monday.
Yeah.
Is that not essentially the manual muscle test for the ipsilateral side of that CM, the position you just put them in? Because if it's a full stretch on one side, would it be?
Okay, you're saying for this left side, would it be, could you use that to test that SCM that's not being stretched?
Right.
Yeah, you can.